Hello, future nurses. Today we're going to be talking about our organ transplants. So in order to be a donor, you do have to be well informed, at least 18 years old, in good physical and mental health, and must share the transplantation antigens. So what we're talking about are the leukocyte antigens. So the things on our cells that basically kind of identify who we are. And the reason why we want them to share these same kind of antigens is because what we want is for the organ to not be rejected. So they'll have things like homografts or oleografts, which come from the same species. So that's human to human donations. The most likely way to not get an organ rejected is, for example, and we'll talk about this when we get into burns, if you were to remove part of your own skin and put it somewhere else, then you're not going to have rejection. You're going to have a more successful graft. Now, that's not always the case because there are times when people need different types of organs like a kidney or anything like that. So we have to get those from other people. So when I used to work in the ICU, we would have TDS. They're the Tennessee Donor Services. They would come in quite frequently to our unit, and they'd be able to kind of, the first thing they would do is take a bunch of lab tests on a patient who had been decided that they were going to be donating their organs. And the reason they do all those lab tests is, once again, to try to see, do they have similar antigens to the people that are on the donor list? And then they would go based off of who was at the top of the donor list. So that's kind of where these donation requirements come from. And for like the good physical health, with that, we want to make sure that we're placing organs that are going to be successful. So if you're like a diabetic, then it kind of almost automatically kicks out your pancreas to be donated. If you have a history of COPD, then you can't donate your lungs. So there's like certain things like that where they're very particular about who can donate, who cannot donate. These are some of the common transplant rejection medications. We've got our cyclosporin, which is one of the medications that we use to keep a organ from rejecting. It's usually used with kidneys. With it, you do have to kind of watch out for toxicity as well as impending transplant failure. So in the acute stage of organ transplant, if you're seeing like these onset of fever and pain, it's very concerning that the patient may be rejecting that transplant. So you just want to watch out for that. Also watching out for things like signs and symptoms of toxicity, such as your headaches, your hypertension, as well as elevated creatinine. So you do want to watch your creatinine. We do use different types of steroids. Now with it, with your steroids, you just kind of want to watch out for the usual things that you'd watch out with your steroids. We've got our sorry, let me be on pause for just a second. So we've got our monoclonal antibodies, which are basically these man-made proteins that act like human antibodies in the immune system. What they're basically used for is for patients that are at risk for steroid-resistant rejection of a graft. They can act like those antibodies and help with that. We've got the lymphocyte immunoglobulins. They're usually used after a kidney transplant. With those, they basically are used to treat aplastic anemia. And with it, there's just certain things that you want to keep at bedside, like things like epinephrine. While they're receiving the infusion, you just want to make sure you're watching their vital signs. And you can pre-medicate with acetaminophen. And usually this infusion fusion takes at least 4 hours. So that's the thing with it, it's a very long procedure. And like I said, it's usually used after a kidney transplant. And it's just to hopefully help treat that aplastic anemia. So when you're educating your patient, just let them know it's going to be at least 4 hours, that you can give them a little bit of acetaminophen prior, and that you're going to want that epinephrine and taking vital signs during it. So these medications can be dangerous if they're over or underdosed. So you do want to monitor for that toxicity. Like I said, for your cyclosporin, looking for things like your headache, your hypertension, and that increased creatinine. These medications can make the patient immunocompromised, so immunosuppressed. So you do want to monitor for infections. So when it comes to rejection, we've got this hyperacute rejection. So this basically occurs within minutes. That's why it's hyperacute, because it happens very quickly. So what happens is the patient's antibodies immediately attack the transplanted organ. So this may result in a systematic clotting and inflammation. So you're going to see that fever and acute pain. With it, the organ is immediately removed. So anytime you see that fever and acute pain, we're thinking of organ rejection. So if you are talking to your patient, usually, like I said, this happens pretty quickly. So as soon as they kind of see it, they're going to immediately send them back to the OR and take that organ out. Acute rejection usually occurs within 1 to 3 weeks. It does not necessarily require organ removal, and often immunosuppressed medications are increased to maintain organ viability. So basically what happens is we're going to increase their medication in hopes that they won't continuously reject said organ. Chronic rejection, a lot of times the organ may be kept within the patient until it fails. So while medications may be increased, it is often considered unavoidable and irreversible. So they can't really fix this chronic rejection. They may encounter acute rejection episodes, and the medications may be increased for a short amount of time and then go back to their normal stable point. So they'll have like these ups and downs with it. So graft versus host disease, like I was talking about before, we've got, it's called allograft or it's called homeograft, but those are basically coming from the same species. So this is basically, I received a donation from another human. Now with it, the best way to like not have this graft versus host disease happen, or the best way to do it would be if we were to give, like, for example, 2 siblings a transplant and their antigens were very similar, or vice versa, if you were to receive a donation from yourself. Like you got a very bad skin graft, so they had to remove skin from one area, put it to another, and then that's would not reject itself because you know yourself. So with this though, it results from stem cell transplantation. The graft, which is the stem cell transplants, attack the host tissue. Most common organs affected are the eyes, skin, GI tract, and lungs. So your common symptoms, like I said, are your maculopapular rash on the hands and soles of the feet, severe abdominal pain, bloody diarrhea, and scarring of the bronchioles. So with this, if you see like this maculopapular rash, then we're getting concerned that you're having a graft versus host disease. Usually your treatment is to increase their immunosuppressive medications. So your kidney transplants will work immediately, and they often produce large amounts of urine the first day. So urine may look a little pink colored, and that is considered normal. If the new kidney transplant patient is not producing large amounts of urine, the patient is at risk for organ failure. So that's like the kind of thing that you want to look for when you're looking at your kidney patients. Kidney transplants are highly successful. Most common cause of death post-kidney transplant is not typically kidney related. So that's something that's kind of good about this. So there's different kinds of organ transplant. You can have living, the donor is alive. So that's things like kidney, liver, portion of the GI tract, portion of the pancreas, portion of the lung, stem cell, which I've got a video on here that we'll watch about stem cell for it. But yes, these are all where the donor is alive. So it can be something like so-and-so needs a kidney and a sibling gives them said kidney or a portion of liver. Then you can have deceased, where the patient has passed away and they're donating their organs. The only organ that cannot be transplanted is the brain at this point in time. So with that, like I said, when we worked with Tennessee Donor Services, they had to go through like pretty rigorous tests before they would accept organs to actually harvest them. So yeah. And as you can see on this picture here, you've got the recipient, they're getting a portion of the right lung from one donor, left lung of another donor, and they're kind of going into the recipient. Some of your common organ transplants include kidney, stem cells, and liver. I did want to give like a quick refresher of bone marrow aspiration. You all did learn this last semester, I believe, but I just kind of wanted to remind you about it. Mostly because in the video that I'll show, and you can see it online on Momentum, it kind of goes through this. So with it, it's usually done under local anesthesia or conscious sedation. You place the client either prone or sidelining, exposing the iliac crest. It's a sterile procedure. You apply pressure to the site post-procedure. Bed rest is for 30 to 60 minutes. Apply ice, monitor for infection, avoid any of your aspirins or any anticoagulants, and it can be painful. So just make sure that they know that it's going to cause them a bit of pain. There's a local anesthetic that they give with it, but they still are going through the bone, so it can feel like a bit of a pinch. Your biggest concern with it is watching for that bleeding. That's why we put them on bed rest. So just making sure that you're watching it for bleeding with that. In this video here, you can kind of see it. It just kind of goes through the steps of somebody wanting to donate. All right. Well, thank you all. I hope you have a good day.